You're listening to Fast Facts Perio Edition. And now, here's your host, Katrina Sanders.
Hello, and welcome to Fast Facts Perio Edition. Hello, friends. Hello, peeps. Hello, perio-loving people. It is such a delight to be here live in living color in your ears. I'm actually here sitting on my hotel room bed in Austin, Texas at the American Academy of Periodontology annual session meeting. And I, first of all, have to apologize if my audio is weird, but I wanted to just hop on and record this because I thought this is just too good and I have to share this with my Fast Facts loving peeps. So today I was in the Hygiene Symposium at the American Academy of Periodontology. It's a full-day workshop designed specifically for dental hygienists. And I will say it was absolutely incredible because we had doctors literally from all over the world fly in to help present and to share some of the strongest updates or newest clinical considerations inside of how we deliver care for our patients. And I wanted to share with you 3 key takeaways that I pulled out from the morning session. So we had an amazing speaker talk about peri-implant disease, peri-implant health, and some of the key contributory factors that we as dental hygienists need to think about when it comes to delivering care for our perio and particularly dental implant patients. She began the program by sharing, first of all, the vast majority of the time when a patient is receiving a dental implant placement in a perio practice, these are patients where we have been struggling to control their periodontal condition. Not always, but a decent portion of the time, we're talking about patients who are struggling to control or manage some of their oral health conditions. So if it's a periodontal patient and that periodontal disease has gone uncontrolled and now we're talking about extractions and dental implant loading, we've got a patient who, from a phenotype standpoint, from a genetic standpoint, from a systemic standpoint, from a biofilm control standpoint, whatever it might be, that they've struggled to maintain their own teeth. So this speaker early on began in talking about how important it is to ensure that we are controlling that disease process before we begin loading dental implants in the mouth. The speaker also talked about the fact that, yes, we can have patients who have advanced decay, failed root canals. So patients who have experienced extreme decay risk is another grouping of consideration for us. So early on in the implant management and maintenance system, as a dental hygienist, even before the patient gets the prosthetic loaded, whether that be a crown, a bridge, a partial or a full fixed prosthetic device like a denture of some kind, before the patient even receives the prosthetic, we as dental hygienists can and should be educating our patients on how to care for the rest of their dentition and be prepared for what they should expect when it comes to care for their dental implants. I share this because I'm going to give you my 3 key takeaways around dental implant modalities that I took away from my meeting today here at the AAP. And you'll notice that biofilm control is a critical aspect of these modalities. So the first key takeaway that I thought was quite interesting is the fact that in research studies, the ability for the patient and the clinician to be able to have access for cleansability around a dental implant site is extremely critical. In fact, this research study that was published in 2009 looks at the ability for the patient to be able to perform their own oral hygiene. And it was discovered that if the implant site itself was cleansable, meaning the architecture, the vestibule, how the implant was loaded, the device on top, all of those things, that if the implant was loaded in a way that it was cleansable, that only 18% of those implants ended up developing peri-implantitis. Now, that's important because we also learned today, and we'll look at this in a minute, we also learned that there are other contributory factors aside from biofilm that can lead to implant failure or peri-implantitis complications. But in this specific scenario, we're talking about cleansability. So we know 18% of the time, it may not be biofilm related. 18% of the time, it could be something else. But if a patient is able to cleanse the area, they've got about 18% of the time, we will still see a development of peri-implantitis. Meanwhile, if the patient cannot cleanse the area, there's a 65% prevalence of peri-implantitis. So such a steep incline like that gives us some really important information about how important it is for the patient to be able to fully cleanse or perform their own self-care around those dental implants. And that becomes a really critical aspect to peri-implant success. So that's key takeaway number one. Key takeaway number two actually looks at the concept of removal of the suprastructures. And this is a research study that was done that looked at non-surgical management of dental implants. Interestingly enough, in this research study, the clinicians did an in vitro study looking at what was the best, easiest, or most efficient way to be able to disrupt the biofilm and decontaminate the dental implant surface if a advanced peri-implant debridement procedure needs to be done. So in these decontamination procedures, one of the key components that demonstrated success, rather the patient's peri-implant surfaces responded favorably to non-surgical treatment. One of the key ways that we got success in this research study was through the removal of the bridge, the crown, the prosthetic device, etc. That when that removal professionally in the dental office happened, that it provided greater access for the clinician to be able to perform that non-surgical decontamination or that non-invasive procedure to treat or address peri-implant disease. So the second key takeaway that I took from this was if we need to perform advanced treatment around a dental implant, we're going to get a more successful outcome if we are able to remove that superstructure for optimal cleansing efficiency. Okay, let's get to that third key takeaway. The third key takeaway, I already kind of alluded to a little bit, looks at the contributory factors that can also point to peri-implant disease and potential peri-implant failure. And there are three key contributory factors. This is beyond biofilm control. There are three key contributory factors that we look at that can readily predict if we're going to be experiencing implant complications. The first is a shallow vestibule. And y'all know what I'm talking about, especially those of you who are treating dental implant patients currently, that gosh, whenever you've got that shallow vestibule, you're trying to retract that tissue and get in there to cleanse that area, that is going to create cleansability complications professionally as well as at home for the patient. The second of these contributory factors is a lack of keratinized tissue. And this is something we will see sometimes in non-compliant patients, but we recognize that lack of keratinized tissue can also be in complicated cases where maybe the patient has had a lot of recession on that tooth, and now that tooth is being extracted, and we're going to go ahead and load a dental implant in that area. Well, if we see lack of keratinized tissue in other areas of the body, that can create a complication. We recognize that the tissue, particularly keratinized tissue, provides a protective barrier or membrane for the dental implant. So if we see advanced levels of disease, and I share this because we've got a large body of patients, do we not, who have attachment loss and are just buying their time until they choose to have that tooth extracted and have a dental implant loaded. The longer that we allow that lack of keratinization to occur, the greater the concern is that we may not get optimal response when we load a dental implant. The third of those contributory factors is tissue thickness of 2 millimeters or less. When we see a lack of tissue thickness, or what we call a thin gingival biotype, and we see that around dental implants, it typically is associated with greater marginal bone loss around a dental implant, again, because of that lack of that protective seal. So we know if we probe a patient, for example, and you can see the black lines of the probe through the tissue, that is a terrific indicator that that patient has a thin biotype. And that is quite concerning. That tissue thickness is quite concerning around a dental implant. It certainly can mean that cleansability will become a complication, protective elements will become a complication, and we could see greater marginal bone loss. Okay, you guys, so those are my 3 key takeaways around dental implants, coming to you live from the American Academy of Periodontology here in gorgeous Austin, Texas. Number 1, access to plaque control improves the risk associated with peri-implant disease. Number 2, removal of that suprastructure for non-surgical treatment will result in increased cleaning efficiency. And number 3, looking at the contributory factors of a shallow vestibule, lack of keratinized tissue, and tissue thickness of 2 millimeters or less could be associated with other extraneous complications around a dental implant. This has been another episode of Fast Facts Perio Edition with Katrina Sanders. Please feel free to reach me on Instagram at The Dental Wine Hygienist or on my website, www.katrinasanders.com. Cheers.